Hi, everybody. I'm Dr. Jianhen Lin from Taiwan. It's my great honor to be the moderator of this topic, sodium bronchiolitis guidelines. And the speaker is Dr. Adrian Harbin from Saudi Arabia. And let's show our warm welcome for Dr. Adrian Harbin. Please.
Hi, good evening, good morning. This is Dr. Adel Habi from Riyadh, Saudi Arabia. I take this opportunity to thank you and thank the organizing committee for their kind invitation. Also, would like to thank our chairperson for the nice introductions. Today, I'm going to talk about Saudi bronchiolitis guidelines that's been already published in 2018, where we cover topics of infections, management, preventions, and it was published in Annals of Thoracic Medicine. It was being recognized very early in 1956 by Professor Morse from South California when they noted our outbreak of coryza in a colony of chimpanzee, and they call it chimpanzee coryza agent, which is reflecting nowadays respiratory syncytial virus. Publication-wise, in 2010 May, Lancet, there was a big systemic review and meta-analysis to estimate the global burden of acute lower respiratory tract infections due to respiratory syncytial virus in young children. And if you see this worldwide map, you will note that there are scattered published and unpublished data worldwide. However, in our area in Middle East, Saudi Arabia, there was very scanty or probably diminished data. For that reason, we went through this local and regional as well as international guidelines, and we aimed at that time to build a national guidelines. In the same paper in Lancet 2010, it was being shown that globally the burden of disease attributed to respiratory syncytial virus remained unknown. However, in 2005, an estimated 33.8 million new episodes of respiratory syncytial virus associated with our acute lower respiratory tract infections occurred worldwide in children younger than the age of 5, and with at least 3.4 million episodes of representing severe respiratory syncytial virus associated with acute lower respiratory tract infection that necessitating hospital admissions. In the same paper, they estimated that around 66,000 to 200,000 children younger than the age of 5 died from respiratory syncytial virus in 2005, with 99% of these deaths occur in developing countries, and its incidence and mortality can also vary substantially from year to year in any settings. And among those viruses that cause bronchiolitis in children, RSV is accounting 62%, followed by another viruses like adenovirus, chlamydia pneumonia, mycoplasma pneumoniae, and other viruses. For that reason, we designed and we asked ourselves, do we need to have a local guidelines? And we decided to make our guidelines about bronchiolitis in children, and we give it a name, Saudi Initiative for Bronchiolitis Diagnosis, Management and Preventions, and we give it a symbol abbreviations, CIBRO, taking the first letter from each word. And CIBRO is talking about what I will discuss with you, the methodology, the strength, some highlights, and what is it and why we have decided to make it. So a SOBRO is a guideline was prepared by the Saudi Pediatric Pulmonology Associations, which is a subsidiary of Saudi Thoracic Society, when we noted how common are such conditions in our country and how urgent it is to have a national guideline according to the latest and best evidence-based practice. This guideline aims to help pediatricians, general practitioners when managing such conditions. And this guideline was published in Annals of Thoracic Medicine, and it was being prepared by a group of experts, not only from pediatric pulmonology, but from pulmonology, infectious disease, neonatology intensive care services, representing multi healthcare settings and from different regions of the country. These are the pictures that been taken in the first day of the meeting in 2017. This is the first gathering or meeting for the expert panel, and we would like also to thank our international experts for the reviewing this guideline, namely Professor Paolo Manzoni and also Professor Kefer Carbonell from Italy. We don't have any conflict of interest, and all the financial support sponsorship of this guidelines came from the Thoracic Society. And why we chose or why we decided to do SOBRO, as I said, when we noted how common is the problem in our region and how important to have a national guideline according to the latest best evidence-based practice. The methods that we used, we reviewed numerous guidelines aiming to extract the best evidence in the management of bronchiolitis. To construct this guideline, the panel meet twice physically and virtually as well. During the first meeting, the panel discussed the available evidence while it graded the evidence during the second meeting. Grading the evidence was inspired from the recommendations in the Center of Evidence-Based Medicine websites. And we use also the level and corresponding type of evidence from A1, from 1A, 1B as follows. And the strength of this guideline, it is a national guidelines, and there are only few documents in worldwide. It's also issued by scientific society in the area of pediatric pulmonology, and it gives many evidence-based responses to questions regarding management, diagnosis, as well as the prevention of the disease. It is the number 9th internationally, which means there are 8 international guidelines, and also it has a geographical, cultural, racial variables, as well as being separate document tailed on a national backgrounds of practice and visibility. It qualifies for a high likelihood of widespread acceptance in our region. It's multi-specialty scientific societies, not only pediatric pulmonology, but it also been involved by neonatologists, pulmonologists, infectious disease, as well as intensive care doctors. SOBRO provides a guidance on diagnostic approach, use of medications, indications for hospitalizations, indications for good use of oxygen, and also the updated RSV prevention. We chose the definitions of bronchiolitis, which was being published in 2006 by the Subcommittee of American Academy of Pediatrics together with the European Respiratory Society, defined bronchiolitis as a constellation of clinical symptoms and signs, including a viral respiratory prodrome, followed by increased lower respiratory tract efforts and wheezing in infants less than 2 years of age. Epidemiology-wise, we went through the international prevalence of the disease. We compared it also with our national data from different regions of the country. And as you know, RSV infection spread and sequelae started as upper respiratory tract infections, which usually a mild disease, and then through the intercellular transmissions lead to terminal bronchioles with some efficient virus replications and ultimately acute inflammatory changes with some immediate responses that might affect viral host and non-immunological factors to lead to airway obstructions and trapping, where the child can present with wheeze, atelectasis, and bilateral hyperventilations. And these symptoms can progress from mild disease, upper respiratory tract, to the lower respiratory tract infections, to ultimately severe respiratory infection, especially in a certain group of patients, like high-risk patients, such as premature babies or babies with comorbidities. As you know, RSV infections in premature infants has been associated with long-term respiratory morbidities, and also can lead to wheezing up to 60% of premature infants, as well as also it has some data shown that RSV can lead to asthma-like symptoms, suggested that the early severe lower respiratory tract infections can be attributed to RSV associated with development of asthma later in life, and this has been well documented in literature. Data from large population-based birth cohort found the accumulative prevalence of asthma was 38.4% in RSV-infected children versus 21% in control children. We also discussed the differential diagnosis of bronchiolitis. In most of the cases, the diagnosis of bronchiolitis can be clinically evident. Further tests are usually not indicated. However, other diagnoses may be associated with an infant with a typical presentations, and many viruses other than respiratory syncytial virus are implicated in the diagnosis of acute bronchiolitis, especially in human pneumovirus, parainfluenza, or rhinovirus, and less commonly reported literature like influenza, Boca virus, adenovirus can be also attributed. However, pertussis and mycoplasma could be also a concomitant infections. Aspiration is a common in severe respiratory RSV infections and attributed to the degree of respiratory distress necessitating admissions. The bronchiolitis is also difficult to distinguish from the first episode of asthma, especially in those with high atopy in the family or a good responder to the bronchodilators and also steroids. And we went through this in our guidelines to differentiate between those two groups of patients. Wheeze crackles are common manifestations in multiple other respiratory conditions such as cystic fibrosis, ciliary dyskinesia, cardiac or immune deficiency, and this condition should be also looked at and it should be ruled out. Some of the patients are also having comorbidities of this, and also we went through this in our guidelines. The diagnosis is based typically on history and physical examinations. It's very rarely to have some laboratory test. However, viral cultures, traditional cell culture is not really indicated. However, antigen detections, either by direct immunofluorescence assay, rapid antigen detection tests are indicated for a purpose of the diagnosis, and as well as the infectious control measures. It's very important to promote identifications of the specific viral etiology for lower respiratory tract infections, where we can permit early implementation of hospital infections control measures, diminished unnecessarily antibiotic use, minimizing unnecessarily diagnostic workup, as well as reducing hospital stays, plus minus rule out other conditions which might require differential and different management approach. And Cipro as well, we discussed the managements from different aspects. As you know, acute bronchiolitis management is mainly supportive, where minimum handling is needed, and also oxygen support. However, we went through this 17 component or 17 part of the management, starting from oxygen therapy, airway clearance, feeding and hydration, bronchodilator use, hypertonic saline use, glucocorticoid, either inhaled systemic use, combined inhaled steroid as well as bronchodilators, antiviral, antibiotics, and so far. So we went through all these 17 elements to discuss in details. The outcome as well, we utilize the importance of anti or prevention measures when we don't have antiviral treatment for RSV. So we stress in the point of comprehensive hand hygiene, second-hand smoking avoidance, breastfeeding encouraged, and also we went through the only medical therapy that is available to prevent RSV, which is the monoclonal antibodies, Synagis or palbociclib, and we went through this in detail in terms of the importance of the use, the mechanisms of actions, as well as the dose, and how we can guide our healthcare providers to run a successful program country-wise. And not only that, we went through some very useful tables in our guidelines for the recommendations of use and the indications, as well as some guidance how to use this guidance in very simplified way, providing a table for the dosing and the follow-up, as well as conducting seminars also with some meetings face-to-face. And during the era of COVID-19 also, we went through many country-wise virtual webinars for educations. We call it cross-country outreach RSV preventions. And this guideline is being published, as I mentioned, in Annals of Thoracic Medicine, and this is the way that you can cite for. We designed a poster for the simplified poster for the can be used in the clinic. Also, we made a hand booklet, and we did annual conference for this guidelines for a purpose of awareness and increasing the awareness of healthcare providers in the country to ensure widespread of the guidelines. So in conclusion, bronchiolitis is a common reason for hospital admissions. Managing bronchiolitis is mainly supportive. Clinicians should be having a special attention for infants belonging to the high-risk group, and SUBRO, which is the Saudi Initiative for Bronchiolitis Diagnosis, Management and Prevention, is the national guidelines, customized one, evidence-based, and it is number 9 internationally, and it is being designed by multi-specialties, aims to help pediatricians and general practitioners when they are managing a condition. SUBRO, it is a flexible, programmatic approach, and I would like again to thank you for giving this opportunity to talk today, and thank you again.